and thank you for inviting me. I'm really glad to be here. My name is Elisa Stromaccioni, and I am an anesthesiologist, and I work in a neurological center of Latium that is a neurosurgical and neurological hospital in which we have a little reality or an intensive care unit. So I will talk to you about analgo-sedation in intensive care unit, mostly reporting our practice guidelines in Italy. Okay, so the first thing I want to do is to focus the attention on the changed concept in the last years from sedation plus analgesia to analgo-sedation, thus focusing the attention on pain management and pain control also in intensive care unit patients, not only in the post-surgical context, and this is in Italy really important. The general aim of analgo-sedation in intensive care unit is to give a constant and adequate level of analgesia, anxiolysis, amnesia, and sedation when they need in our patients, and in patient that needs intubation and mechanical ventilation is to facilitating the adaptation to mechanical ventilation, thus reducing the use of neuromuscular blocking drugs that we need to avoid this use in intensive care unit most of the time, not all the time, and to avoid accidental extubation that can improve our patient outcome. Surely, the reduction of metabolic response and catecholinergic response to stress, and avoiding the increase and sudden increase in intracranial pressure. So the first step to do is to evaluate both pain presence and level, and the level of sedation in our patients. All critically ill patients, as I said before, as the post-surgical patients, need to have the right to adequate analgesia and management of the pain. If we are in front of conscious patients, we can use the well-known visual analog scale or numerical rating scale, and it is the patients that will tell us, I feel pain, this is my level of pain. Unfortunately, in the ICU context, we always most of the time we are in front unconscious patients that are unable to communicate. So we can use observational scales such the CPAT, this is a critical care pain observational tool, or the behavioral pain scale. They are based on the general observation of our patients, so facial expression, the movement of upper limbs, and in ventilated patients, the compliance with the ventilation, and vocalization in non-intubated patients. We need to do this daily, frequently during the day, and at rest, and during the most pain procedure. So this is the second point to evaluate the kind of pain. We have a pain that is at rest, so due to the obliged positioning on the bed, maybe to the presence of bed sores, and we have a procedural pain due to the daily activities in an intensive care unit, such as the daily care of our patients and their mobilization, the need to take a central venous access and the bronchial suction. So we need also to have a drug strategy to treat this kind of pain. We need to evaluate daily and frequent the level of sedation of our patients, so to avoid both over or under sedation that are both detrimental to our patients for our outcome. We have subjective methods such as the Richmond agitation sedation scale, or the Ramsay sedation scale, and so on. The one that we used is the Richmond scale. Is a validated scale that goes from 0, where the patient is calm, to 4 positive points that individuate different level of agitation, and 5 negative points that individuate different level of sedation. So ideally we need to stay in between +1 and -1. Evaluating the RAS we will need to do it very frequently during the day. So ideally, it could be good to adjunct, an objective method for evaluate sedation in intensive care unit. However, there are no evidence of potential benefit of the use of bispectral index that is quite good in the surgical context. There are recent studies shows a potential benefit on adding continuous EEG to the evaluation with the RAS scale for a better outcome of our patients. So this could be a future step. Very simply, we can differ different kind of sedation basing on the length. We have to remind that obviously basing on the necessities and the characteristic of our patient, the less the analgo-sedation, the better the outcome. So we need to evaluate, that's why we need to evaluate every day. We go from a short time to long time if we are talking about a sedation time for more than 3 days. Before talking about different kind of drugs that we use, I will take some general pharmacological consideration. We need to take in account that intensive care unit patients can have renal failure or liver impairment or both together. And this can lead, for example, to increase in free fraction of the drug and can change the behavior of our drug. Can lead to accumulation of some drugs and due to the reduced enzyme activity. So we need to take in account also that not all, but most of intensive care unit patients in the neurological context are elderly. So we need to take in account the changes in the pharmacokinetics of these kind of patients when we choose a drug. Last but not least, we need to take in account the way of infusion of the analgesic and sedative drugs. That is probably in the intensive care unit context the continuous infusion. These guarantee a constant level of analgo-sedation. There is the relative risk of accumulation and higher drug consumption, but if we pay attention, this is quite not important side effect. But when we have to choose a drug and we choose to use it in continuous infusion, we need to talk about the CHST. This is the context sensitive half-life. It is very simply the time necessary to the drug plasmatic concentration to become half after a period of continuous infusion. As you can see in this graphic, it could be really different from the half-life as it goes, for example, for fentanyl, and it describes better the behavior of our drugs in the clinical context. So it helps us to choose the best drug to use. Choosing a drug with a short context-sensitive half-life allow us to have a fast recovery, lower accumulation, and fast weaning, and easier neurological daily assessment. So now we can talk about different drugs. One drug with all these characteristics, unfortunately, we don't have one only drug, but we can use different kind of drugs to reach a good level of analgo-sedation. So with a rapid onset, no active metabolites, and all these characteristics that that are here. So let's talk about analgesic drugs. In between all the analgesic drugs, opioids are maybe the best choice. Opioids are a well-known group of substances that act on mu-Ki and delta receptors on the central nervous system. They provide a powerful analgesia, both for acute and chronic pain. In between all of these, maybe the best choice for continuous infusion in intensive care unit is remifentanil, because of its short context-sensitive half-life, because of its extrahepatic metabolism, and also for its pKa. that is lower than pH, and it guarantees a constant power, analgesic power of the drug in a wide range of on a wide range of modification of physiological pH in between 7.2 and 7.6. So this is a good choice. Surely analgesic drugs like opioids has some side effects. For hypotension and muscle rigidity, mostly when a bolus is given. So this is why it's recommended to have a single venous line for opioids infusion to avoid suddenly and bolus. Bradycardia and respiratory depression, talking about remifentanil at the low dose of continuous infusion of remifentanil are not so frequent side effects. So immunodepression seems not to be clinically relevant, while bowel dysfunction it's really common. I will talk later about the tolerance and withdrawal syndrome. In between the analgesic drugs, we can choose also non-opioid analgesic because of the sparing effect on opioids. They can help us to reduce the dose of opioids. This is the Italian acronymus for NSAIDs, non-steroidal anti-inflammatory drugs. We can use it mostly in the post-surgical context, no more than 5 days, because of the risk of gastrointestinal bleeding and renal toxicity. Paracetamol is a good drug to use for its sparing effect on analgesic sparing effect on the opioids, but we need to take in account its hepatic metabolism and its antipyretic effect. In between sedative drugs, we can choose a well-known group of benzodiazepines. They enhance the power, the effect of the GABA transmitter, enhancing acting on the neurotransmitter, enhancing its binding to the GABA receptor, thus giving analgesia and sedation, hypnosis, amnesia with anticonvulsivant properties. So they differ each other for the onset time and the length of activity. Maybe the best choice in intensive care unit for continuous infusion is midazolam. They have side effects that we need to take in account. So they reduce response to hypoxia. They give hemodynamic changes, not so important, but they do, decreasing blood pressure and heart rate. They can lead to paradoxical agitation, delirium, mostly in the elderly patients. They have an hepatic metabolism, so we need to take in account, and we need to take in account the possibility of comparison of tolerance and withdrawal syndrome, and we'll talk later. In between these drugs, we can choose propofol. It's a drug that acts on GABA2. It decreases the rate of dissociation of the neurotransmitter from its receptor. So it gives sedation without analgesic power, sedation, hypnosis. It is a really fat soluble, so it crosses the brain barrier very quickly. It has a really rapid onset and a rapid recovery. It is good in continuous infusion for more than 72 hours. It has a short contextus-sensitive half-life. It has several side effects too. We need to take into account the hemodynamic changes when we use propofol, so it's not good to use it in non-hemodynamic stable patients. It can increase the triglyceride concentration, and in intensive care unit we need to take in account also this. And a high dose of propofol of more than 5 days is related to a really severe syndrome called the PRIS, propofol-related infusion syndrome, that is due to probably an impairment of fatty acid metabolism in the mitochondria that leads to rhabdomyolysis, kidney failure, till the cardiac failure and metabolic acidosis that can destroy our patient outcome. So it is recommended not to use propofol more than 4 days for high dose of propofol. Last but not least, dexmedetomidine. It's probably the best choice now. It is an alpha-2 agonist that acts on alpha-2 receptors in the deep brain as clonidine, but more selective for the brain receptors. So it gives a potent analgesic sedative properties without respiratory depression, and it also has a sparing analgesic effect on opioids. We can use it in continuous infusion, and it is helpful to give an arousable and cooperative sedation in our intensive care unit patients. It could be the best choice. It has several side effects, hemodynamic side effects, a short therapeutic range, so it is not so manageable. And in Italy, it is still a really expensive drug. So now we'll talk to you about tolerance and withdrawal really shortly. It is after a long-term analgo-sedation, this kind of side effects reaches from 20 to 8%, relating on the length of our sedation. So the less the analgo-sedation, the better the outcome. There are several signs and symptoms that can help us to have a fast diagnosis and a fast treatment of this kind of side effects. So some of them are spasmodic desire of drug, anxiety, cramps, delirium, irritability, and so on. We can act mostly by preventing the appearance of this side effect by reducing the time of analgo-sedation, but most of all by not suddenly stop the drug, but programming a progressive reduction of drug dose when we want to evaluate our patients and we want to stop analgo-sedation. We don't have to do it suddenly, but we need to have a strategy, a progressive reduction. If you are in front of a withdrawal syndrome, the best way to for a better outcome is to treat it very fast. With alpha-2 drugs like dexmedetomidine, it's the best choice, and treat delirium if present with haloperidol. So generally, and concluding, every day we are in intensive care unit in front of a patient that needs analgo-sedation. We need to ask ourselves if the patient is feeling pain, and we need to evaluate daily at a different time the pain level at rest and during the most painful procedure. And we have to have a specific drug strategy for pain management of procedural pain. We have to ask ourselves too if the patient needs to be sedated and why he needs to be sedated. We have to evaluate very frequently during the day the level of sedation to avoid over-sedation and under-sedation that are both detrimental for our patient outcome. And we need to have a daily progressive suspension strategy, progressive reduction of the drug dose to evaluate our patient for our patient weaning. We need also to have a rotation strategy of different drugs if we think or we are in front of patients that needs an analgo-sedation period longer than 8 days. We need to prevent the withdrawal syndrome with, as I said before, the progressive reduction of the drug dose, and to treat it very fast if we are in front of this kind of side effects. So to improve our the general outcome of our patients. That's all. Thank you.